Thank you. Senator Chambliss.
Maya, you talk in your testimony about 3 reform measures that have the potential to drive down costs, savers, benders, structural changes, I believe is the way you put it. What I'm interested in is how we get Medicare beneficiaries to get more skin in the game. How do we get that individual who goes to the emergency room to think, gee, if I go next time, it's going to cost me $25 or whatever it may be. I couldn't decide whether that might be low-hanging fruit and savers or whether that would be in your structural. But if you will, talk about that for a minute and tell us your thoughts on how we get that more skin in the game attitude out there.
So I would put that squarely in the benders category, which is where I think we should be focusing as much of our energy as possible right now, in that it can save significant money in a 10-year window, but more importantly, it would have compounding savings over time. And so I think the real key here, and we've all discussed it to some extent, is that if you have more price sensitivity than you have with a system right now, where you pay for my health care and I pay for your health care, and we all think we should have as much as possible, but if you have more price sensitivity and you have more information in a way that you can evaluate what is good for your own health and what is excessive cost, that skin in the game is critical to bending the curve over the long term. I think we want to be careful. You want to make sure that while you're changing the way that the financing of the incentives and the financing of Medicare, that you do protect people against excessive costs. We know that one of the highest reasons for bankruptcy is health care costs, and you want to make sure that people are protected from catastrophic costs, and you want to make sure that people are protected from paying a greater share of their income than they can. So it's some combination of means testing, but not to the extent where the system unravels for the parts that are voluntary, and greater cost sharing. But nobody should feel that going to the doctor is just sort of a pastime. It needs to be something that you evaluate like you do with all other purchases, whether it's worth it. And I think that's the most important reform we could be looking at right now.
Yeah, would you agree that that is the mindset right now on folks who have been used to the government taking care of their health care, whether it's through Medicaid and then graduating into Medicare, that there is that feelings, consciously or subconsciously, that I'm entitled to this, the government's going to take care of me, and until we change that curve, we're not going to bend that curve, the Medicare cost curve down?
I think certainly there's 3 things that contribute it. One, that you've paid into Medicare, though as we heard in the beginning, you haven't paid nearly enough into Medicare to cover all that you'll be receiving out of your lifetime, but you feel that you've paid into it. Second, that you don't see anything close to the real cost when you go to the doctor. And third, that it's health care. And so everybody can work themselves up into a tizzy that this has got to be, vastly important. I have to go to this doctor for just in case this is a serious thing. And you lose the ability to evaluate whether it's worth the cost. But those 3 factors all contribute to our overutilization of health care. And I think price sensitivity and better information are the keys to helping bring that back down to closer to realistic levels for demand.
Let me address this to the whole panel. My thought on SGR is that if we don't fix this thing for at least 10 years, we're kidding ourselves. We know we're going to come back and we're going to stick that Band-Aid on it every year. There's no policymaker that could go home and look his docs in the eye without doing that. But if we do that, it's going to be more expensive on us over that 10-year period than if we go ahead and bite the bullet and do it for 10 years. And the second part of that, I am extremely concerned that if we don't come up with a long-term solution to SGR, that we're going to lose docs like we've never seen before. Now, rarely does a doc who is under 40 years of age, under 40 years of age, come into my office, and he accepts Medicare patients. They're pretty smart about going into a field where they don't have to take them, or into a region where they don't have to take them to make a good living. So what I want you to address is, what do we need to do about SGR? We got to pay for it somehow, but am I wrong in thinking that if we don't fix it for at least a 10-year period, that we're missing an opportunity, and that in the long run this is going to cost huge bucks?
I certainly agree with that. Of course, 10 years is forever, as long as you've replaced it with something. You have to find some method of limiting unnecessary growth in health spending and Medicare generally. Now, if you want a short-term fix, MedPAC has plenty of ideas. You spread the pain around. Instead of taking a 30% cut in January for all physicians, you take a much smaller cut on specialists. You freeze specialists and primary care. That's not an unreasonable thing to do. The rest of the health sector has to kick in as well. However, that doesn't fundamentally solve the problem. You still have a fee-for-service Medicare program where, you know, the reason why patients go from doctor to doctor is they don't have a sensible place to go otherwise. So we got to fix that problem too.
I would say certainly you have to fix it. It's ridiculous sort of to do this every year. I mean, and a long-term fix that would be a freeze or a small rate of increase in fees just makes a lot of sense. One thing I would say is even though we come back and we don't let fees fall, and so prices aren't going up, it is important to remember that spending on physician services is going up quite much faster, 7–8% a year, because the volume of services are going up. So that means that the incomes that physicians are receiving are not falling. I mean, that's just not right. But nonetheless, it's not just because they're reacting to the low fees, but because of a lot of other factors, new technologies, new procedures that come along. So I would fix it, but it's not because docs are really hurting because of the current policy.
If I could, I mean, in my testimony, we put in some of the survey evidence that showed the response of physicians the last time Congress didn't pass an SGR patch in a timely fashion, and there's a whole array of things from contemplating not seeing new Medicare patients to actually never seeing them ever again, and I think that it's a tribute to the concern you should have about not fixing it. You have to fix it, or beneficiaries are going to suffer, and it is an artifact of the current law baseline fiction to pretend that this is costing you something. You're going to spend the money because you're not going to let beneficiaries not have access to doctors. I mean, as a Congress, you can't have that happen. You never have. You've always spent the money. It's always ended up in the actual federal deficit. It will end up in the actual federal deficit in the future. And so acknowledge the reality, fix it, and then start realizing that this is a 5% reduction every year in overall Medicare spending, and that's something you're going to need to get to begin with. So, you know, get this off the books, stop messing around with that corner of Medicare, and then fix the program.